Okay, let's start if you don't mind. Uh, so, this session would be about exploring sodium disorders through clinical cases. I should first say that um, electrolyte disorders are one of the hardest parts of nephrology for everyone, not just for you and for the USMLE, for nephrologists the same. Sometimes we have, weekly conferences and we talk about the cases that were difficult, the fellows present, and all the attendings and faculty are there, and we discuss. I can tell you, we get into fight each time we have a hyponatremia case. I do not agree with the next guy next to me. That one doesn't agree with the next one. So it's a very challenging part. I am trying to make it as simplified and easy as it can. Obviously, when you simplify some things, you lose a little bit of precision, but I think it is worth for the exams and the boards. I try to make it in a way that you will memorize hyponatremia, which is one of the hardest parts and the most common electrolyte abnormality. Um, so I am hoping that by the end of this lecture, at the end of the hour or 50 minutes, you will feel comfortable with at least the questions USMLE. For the practice, I'm sure you will. Okay, let's start with a few facts. Fact number one. I came here to talk with you about hyponatremia, and we don't talk about hypernatremia this session because hypernatremia is much easier and it is needing another full lecture. It is hyponatremia. But hyponatremia, as I talk about, is not actually about sodium. When I talk about hyponatremia, you will see that all I am talking about is about water. It is a misnomer. We say hyponatremia, we think about, oh, the sodium is low. Sodium is always good. The majority of the time, the majority, and I say not, I don't say all the time. It is too much free water. It gives us hyponatremia. So keep in the mood of thinking about water more than sodium when we talk about hyponatremia. Fact number two is that the kidneys control serum sodium levels through concentration dilution of the urine to keep the serum sodium between 135 to 145 millimole per liter. Let's call it 140 to make it easy for us. Role of AVP. Do you remember what AVP is? Arginine vasopressin. Is there another name for it? Antidiuretic hormone. Have you heard of it? Antidiuretic hormone is in the brain, comes into the kidney, goes to the distal part of the kidney, the collecting duct, and reabsorb all the water that is in the collecting duct. So the more AVP, the more reabsorption of the water. And that's how kidneys are controlling our serum sodium. If our serum sodium is low, they do not respond to AVP, or the AVP is not secreted. So there is not a lot of water reabsorbed in the collecting duct. All the water is going down. So my serum sodium starts going up, the concentration. The other way, if my serum sodium is going up, my AVP is high, it brings back all the water from the collecting duct. So the water comes in and dilutes back the serum sodium. So dilution concentration through AVP is the way the kidneys handle the homeostasis of sodium. Does that make sense, guys? And we're going to hear about it more so if you didn't understand. So one of the things is here. Let's say I drink a lot of water one day. Remember, just like the potassium, we have our craziness. The kidneys correct us. The kidneys keep us within the stable range despite everything that we do to ourselves. My serum osmolality goes down. And remember, there are three main osmoles in the body. Let's once forever put this outside of our way. There are three things that make our osmolality in the serum: sodium, glucose, BUN. Glucose and BUN are negligible. When we talk about serum osmolality, 99% of the time we are talking about sodium. Because if think about it, sodium is 140 times 2 is 280. That's the serum osmolality. You see that the other parts are not that important. The BUN and glucose. They are important in pathological situations when our glucose, instead of the normal of 100, is 500. it affects serum osmolality. But in normal life, it does not have a major role in osmolality. When I talk about osmolality, 99% of the time, I'm talking about sodium, serum sodium. So when I drink a lot of water, this water goes to my GI tract. It's absorbed. My serum sodium goes down. Is diluted, right? Serum sodium is diluted. Serum osmolality goes down. Okay. My AVP will go down, so there is no water that is reabsorbed in the collecting duct. I have very dilute urine, low urine osmolality, super dilute urine to get rid of excess water, right? The excretion of extra water, homeostasis is back. Does that make sense? So the other side, I am dehydrated, I am running around, I have been sweating, okay. My serum osmolality goes up because I have been sweating, I have lost a lot of water, so I am concentrated in terms of sodium. Serum sodium went up, serum osmolality went up, AVP goes up. AVP goes up, so every drop of the water that goes into the distal nephron will be reabsorbed back into the water. Concentrated urine, super concentrated urine, high urine osmolality, retention of water, homeostasis is back. You see, that's how AVP is working. In other words, if you think about it, to keep my serum osmolality within certain range, my urine osmolality has to vary a lot to get rid of excess water or reabsorb the needed water. Does that make sense? Okay. Fact number three, urine osmolality can be very variable. From the time we drink a lot of water, my urine will be super dilute. I am getting rid of this excess water. It goes all the way down to 50. And if I am super concentrated, super dehydrated, my urine will be concentrated because all the water is reabsorbed back. So my urine might goes to 1200. Think about it. How many labs do you know that the normal range is 24 times more? Think about it, the serum sodium. Normal 135 to 145. Serum potassium 3.5 to 5.5. Urine osmolality from 50 to 1200 is normal. And that's actually how our urine is that good. And you know, one fun fact about it, it's not for you, it's for you. As we age, we lose this part of it. Meaning that you guys are young, you can dilute your urine all the way down to 50. At my age, probably I'm around 70, 80, 100. As we age, we cannot dilute as much as we were doing it when we were younger. That's funny. That part doesn't move, this part does. Okay. One thing that says here, not only super concentrated, super diluted from 50 milliosmoles per kilogram of urine, or because urine is a fluid, you can use liter or kilogram both, right? Milliosmoles per kilogram or urine or per liter of urine. Okay, so look at this. One thing that this part is telling you, if you have thought about it, I said we can super dilute or super concentrate our urine. But did I say that our dilution can go all the way to zero? No. The lowest was 50. As a matter of fact, I told you with aging that 50 will be shifted a little bit towards 60, 70, 80, right? So what it tells you is that we can never have pure water as urine. We have a minimum of osmoles in our urine. This is an important concept. You will see why in a few minutes. Okay, we can never have pure water as urine. We can drink 25 liters, still will have osmoles in our urine. Please, clarity. I tell you once, but you don't need it for the exam. So don't get confused. If you don't understand it, just forget about it. When you go for weight, it is osmolality, kilogram. When you go for volume, liter, it is osmolarity. That's it. The same concept. Yes, but if you think about it, not every fluid 1 liter is 1 kilogram. Even for urine, it's not 100%. For water, it is. For urine, because it has osmosis. So, but we tend to say osmolarity and osmolarity are the same for you if you want to learn it. Milliosmoles per kilogram equals milliosmoles per liter. Okay, perfect. And I think in those two slides that I didn't mention last session, I said this is osmolarity. Let's move on. You have this concept over there. Okay. Should you go for cases? These are really fun cases, I promise. And all of them are real. I think all of them. Okay. Number one is real, real. They called us for a consult 5 p.m. on a Tuesday. I was really in a bad mood when they got the consult. 68-year-old man comes with newly diagnosed multiple myeloma for admitted. So multiple myeloma is a blood cancer where you have some form of immunoglobulin that is secreted in your serum. So you have a lot of protein in your serum. That is abnormal. Medications, he's not on anything. Pre-chemotherapy labs are ordered. So the gentleman comes today, is admitted to the hospital because they want to start chemotherapy tomorrow. So as part of their admission thing, they take some labs. It goes to the lab, and this is what they find. You see that skeleton that I told you we need to remember is up there. So sodium, potassium, chloride. This is sodium is his sodium is 125. He was walking, talking. He was at home. He came to start chemotherapy. Incidental finding, right? They called nephrology. God bless, 5 p.m. Yeah, okay. We checked a few labs. The thyroid hormones were normal. If I can find it. Cortisol is normal. Protein is super high, 12.2. To give you an idea, normal protein is around 8. So it is 50% more than the normal range. And albumin is normal. So because I told you, he comes with multiple myeloma, has that protein, immunoglobulin high. Physical exam has nothing really special to think about. What is the next step? So I have found hyponatremia. What is the workup for hyponatremia? One, two, three. You should remember this in this same order and repeat it so much for yourself that at night you will remember it when you wake up. So you start by saying serum osmolality, urine osmolality, urine sodium. One, two, three. Serum osmolality, urine osmolality, urine sodium. These are the only things that you know and you need. From now on, you will see that I only use these three, and I will tell you everything that you need. For this patient, these are the numbers. It was 281, 495, and 54. These three. Okay? So now let's go to the next one. This is what, ooh, you see, oh boy, another one. But you will see it. It is very easy to know it when you have gone through the different components of it. Now it looks scary to you. At the end of these 50 minutes, I am 100% sure that you all know about this. Number one is up there, serum osmolality. Serum osmolality, here is the deal. Normal, let's say, is around 280. Remember, serum sodium is 140 times 2 is 280. So serum osmolality, if it is 280 or higher, it is normal or high. If you have a serum osmolality that is normal or high, you are not dealing with real hyponatremia. It is either pseudo hyponatremia or it is hyperglycemia. Basically, that's the easy one. You see this, you sign off on that patient. That's not your problem anymore. This is not a real hyponatremia. Just treat the underlying disease. If it is hyperglycemia, this to give the patient insulin. If it is protein high, treat the protein. You don't need to worry about serum sodium, basically. But that's unfortunately only 5% of the cases. 95% is to the left. The right side is the easy part. On the majority, 95%, serum osmolality is low because the serum sodium is low. So you are dealing with this. Then you are going to look at urine osmolality. Depending on if it is low or high, you will make a decision. And if it is high, then you need to go and check the urine sodium to see if it is low or high. And we're going through all of these one by one. But for this specific case, all you need to know is When I have hyponatremia, first stop and only stop serum osmolality. If it is normal or high, have a good day. Easy one, 5% to the right side. If it is not high or normal, then you are starting the rest of your journey. Okay. I put what this patient had here. Remember, the numbers of that patient are here. 281, 495. His serum osmolality is 281. Do I need to do something about this patient? That's a good one. That's an easy one. That's a right side one. More than 280, right? I signed off that day. That was easy. The serum osmolality is more than 280. It is either pseudo hyponatremia or hyperglycemia. Hyperglycemia, you will see it on the lab. Glucose, they will give you the number. But this one was normal. What was the case was that he comes from multiple myeloma. His protein is super high. That gives you pseudo hyponatremia, because it is very easy to explain, but if you don't know the explanation, you don't have to worry about the explanation. Why? High protein, high cholesterol, high triglycerides, high glucose, they give you hyponatremia because they're all in the serum. They take one part of the serum. If they are more than what they are supposed to do, they are going to make it very short for the sodium. The way we are checking the serum sodium is through two electrodes that we put in the serum. So it gives you a false number, basically. So when you have any of these that is high, it is. So we had pseudo hyponatremia due to paraproteinemia in multiple myeloma, and you see the protein was 12.2. We already know that it was super high. So what did we tell them? What should you do for the patient? Have a good day. Treat the patient with chemotherapy that he was supposed to get. Should we go to the case two? So for now, it was the easy one, the right side. But here is it. That was the only one you had. All of them will be the real hyponatremia. I saw this patient when I was a resident. 20-year-old lady comes with no past medical history, was brought to the ER at 6 a.m. for 4 to 6 hours of unresponsiveness. So comes with altered mental status. This is the physical exam, nothing big. There's a little bit of temperature. You saw it here, 101. It's a little bit of fever, but nothing big. The neurology is unresponsive and all those, but nothing that you can get out of it. These are the labs. What's the serum sodium? Wow. 123. What's the normal serum sodium? 140, 135 to 145, right? 140, let's say. This is really low. So this is a young girl, comes, no past medical history, altered mental status. Wow, the serum sodium of 123. This is very, I would say, scary. And I am no neurologist, but I know that if you see too much dark gray thing, it is water. So the patient is having cerebral edema, that brain edema. There's a lot of water in the brain, actually, right? The dark gray. What is the next step? What are the three things I should do? Serum osmolality, urine osmolality, urine sodium. Serum osmolality, urine osmolality, urine sodium. Let's do it. This is what she had. 258, 558, 39. Should we go to our algorithm? Let's go. Okay, I put it down here so you remember her numbers. Serum osmolality over there. Is it high? Should we think about this one? Are we lucky on this one? Is it to the right side? No, the serum osmolality is not. Serum osmolality is 258. So it can't be pseudo hyponatremia hyperglycemia, right? Forget about that. We should go to the left side. It is low, yes, less than 280. Serum osmolality is low. So next step is to check the urine osmolality. We check the urine osmolality. If it is low, and low means less than 100, urine osmolality is low, meaning that it has dilute urine, right? In that case, it's easy. It's primary polydipsia. Basically, if you have a lot of water, but not a lot of osmoles, when you have a discrepancy between the amount of water you drink, the amount of osmoles, like alcoholics. They drink liters and liters of alcohol. It gives them the calorie that they need. So they don't feel hungry. They almost don't eat. A little bit here and there. All they intake is water, is alcohol, right? And they get hyponatremia. Classic feature of alcoholism is hyponatremia. It is all, I don't say it's telling me too much exaggerated what I'm telling you, but it is almost unheard of an alcoholic that doesn't have hyponatremia to some degree, not necessarily severe, right? Very good. So this is, if urine osmolality is low, you have, your kidneys are normal. They're trying to get rid of the excess water. You have super dilute urine, but you keep drinking, so your serum sodium keeps going down, right? Very good. But this is not the case because the urine osmolality in this patient is more than 100, right? So this does not apply to our case. This lady did not come for with altered mental status because of alcohol intake. Let's go to the next step. It is high, yeah, less than 100. So now we need to go to the next step. Check the urine sodium. We check the urine sodium. If urine sodium is low and I have super concentrated urine, it means that I am hypovolemic. I am dehydrated. My body is trying to conserve all the water, all the salt, all the sodium, right? Makes sense. So urine sodium goes down and the urine is super concentrated. Concentrated urine with low urine sodium is always hypovolemia. And we'll talk about it later. But if my urine is concentrated, my urine sodium is not low, or it is more than 30, I have AVP that is secreted for no reason. I have SIADH, syndrome of inappropriate ADH secretion or AVP secretion. Basically, for whatever reason, AVP has decided to just secrete. All the water in my collecting duct is coming down. My serum sodium is coming down. Does that make sense? SI. Why is it inappropriate? Because I am hyponatremic. In normal situation, you should stop the AVP, but it keeps going. Sometimes it is because of a lung cancer. There is a mass in my lung. It is secreting AVP no matter what. It is not regulated. Regulated, remember from, okay? It just keeps going. My serum sodium goes down, right? I can have another things that gives AVP going. Marathon runners. Have you seen the medical tents Boston Marathon? Have you seen? Do you know that they are looking for hyponatremia? Major physical activity gives you AVP that is secreted like crazy. And then on their way that they are drinking, there are water stations. They stop by and drink. You drink at the same time your AVP is putting back all the water. What's the downside? Your serum sodium goes down. Does that make sense? Does it? Very good. So, SIADH, you see all the numbers of this lady looks at this. So we know that she has AVP that is high in her body. ADH and AVP are the same, is high. Working diagnosis is acute SIADH, but that's not the end of our journey. You ask yourself, why? Why AVP is high, right? So that's the question. Then, do you want to do more workup? I hate to say it because you are young, but each time a young person comes to the ED, we check urine drugs. Here we are, urine drug screen. She was positive for amphetamines. When you have amphetamine, and you know what is amphetamine? That's the one that is very exciting thing, right? Ecstasy, basically. And you know, ecstasy is not like your usual marijuana and all those cheap ones. This is an expensive one. They go out of their way, they put actually their brands on it, right? This is not from my personal collection. I took it from Google. So, ecstasy-induced acute hyponatremia. So, don't go through all of this. You should just know that ecstasy, another name for it is MDMA. You are going to hear it a lot. Methylene dioxymethamphetamine. But MDMA is easier to remember, or ecstasy is a love drug. You can read about it by yourself. That I don't go through the. It's not about the drug. It's about the AVP and what it does to the kidney. So it has two effects on the kidney, MDMA or ecstasy. It can give you rhabdomyolysis because these are these rave parties. They dance a lot. They have breakdown of the muscle. At the same time, it can give hyponatremia. And why does it give? That one, something you need to remember is that symptomatic hyponatremia is the most serious complication. Acute SIATH is the most common reason for it, but it's not the only reason for hyponatremia. If you think about it, this is a long list. And each time I give you a long list, my commitment to you is which part of it you need to know, right? I hated when I was in medical school, the professor put a long list without telling me what part is important, as if he knew everything. I don't, so you don't have to either. This is the parts that you need to know. Ecstasy induced AVP is the main reason for hyponatremia, but also it gives you thirst. So not only the AVP is high, it tells you drink water, drink water. Is it good to drink water when you are hyponatremic? Not a good combination, right? And then ready availability of fluids. These young kids, when they are in the party, they have actually back rooms filled with water. They tell each other, if you take ecstasy, go hydrate yourself. That's the worst advice that a friend can give to another one, right? My AVP is super high and I drink a lot of water. All the water goes to the distal nephron and will be reabsorbed. You just get my hyponatremia worse. If anything, I should restrict water. So there would be nothing in the distal tubule that the AVP will bring in. Does that make sense? Perfect. High AVP, a lot of water, bad combination everywhere. So you can read about it yourself. It is interesting. SIADH is more common in women, even if we have the same, not SIADH. SIADH is in both people, but hyponatremia is more common in women, and even depending on what part of their cycle it is, it has something to do with sex hormones. What part of their cycle they're more prone to hyponatremia or less. Meaning that 2 weeks ago, she took drugs, she with water. She didn't have hyponatremia. 2 weeks later, she takes the same amount of drug, the same amount of water. She gets hyponatremia that is severe. So you can read about it yourself. Back to our patient, 25-year-old. What did we do? We gave the patient hypertonic saline, meaning that super concentrated sodium chloride solution. You know, because this patient has brain edema. In a few hours, she will die. She will herniate. The sooner I give her sodium, the serum osmolality goes up. The water from the brain is coming back into the vessels instead of going out, right? So I treat the brain edema with hypertonic saline, which is 35 milliliter per hour we gave her. And you see, this is the time. This is her serum sodium. Started to go up very nice. Okay. And it's not that great. One thing went away for the USMLE. And this is very common. Young woman, party hyponatremia, they are talking about ecstasy. How do you treat it? 3% or hypertonic saline. Okay, not the normal saline that we want to use. Super concentrated because in short period of time, you should bring up the serum sodium quite fast. In general, a rule is hyponatremia. It should be corrected at the same rate that it developed. If it is acute, you should bring it up quite fast. If it has been chronic and alcoholic person, you actually should not correct it fast, right? It should be corrected at the same rate that it was developed. Okay. These are the reasons for SIADH. When ADH goes up for no reason, pain gives you ADH. So if I have a lot of pain and I drink a lot of water, am I prone to hyponatremia? I am, right? Ecstasy, we talked about. Lung cancer or lung disease, we talked about. Intense exercise, I told you about marathon. And some medicines, SSRIs, the antidepressants, they are known to give you hyponatremia because, but these are not severe. You're just going to a doctor's office, they check your lab and they see that serum sodium instead of 140 is 133, 134. You're on SSRI, that's fine. Should we go to another case? So we went for a multiple myeloma, pseudo hyponatremia to an ecstasy. Should we go to another real case? This is a real case again. It is called hold your V for a V. You are not old enough to know what a V is. Do you know what V is? Do you? What is it? It's a video game, right? Xbox. This was Xbox, right? This is the grandfather of Xbox, probably. Do you know what it is? Have you seen one? Okay. Have you seen anybody has seen it? You perfect. So basically, this is the story of hold your V, hold your pee, hold your urine for a V. What is the story? And this is a real story. In 2007, January, in Sacramento, California, Jennifer Strange, 28 years old, died Friday in her home hours after taking part in the Hold Your V for a V contest, in which one radio station, local radio station, promised a V video game for the winner. Basically, this local station came up with an idea, a contest. If you can keep your urine, not go to the bathroom, and drink a lot of water, whoever goes the last to the bathroom will win a video game, right? Does that make sense? Okay. So we want to see if water can be lethal. The contest was about challenging participants to drink as much as water they could without going to the bathroom. So they start drinking. It goes through the detail. They keep drinking. Some people start going to the bathroom. The more they drink, less people are staying. People go to the bathroom. They're eliminated. They go a little more than 3 hours after her first bottle of water. Mrs. Strange dropped out of the contest. She consumed nearly 2 gallons of water in 3 hours, 8 liters in 3 hours. She was runner up to the woman who won the video game. To compensate, she was given 2 tickets for Justin Timberlake. Do you know Justin Timberlake? You see, for we, but Justin, sure enough. Okay, later that day, so she's participating in contest. She drinks a lot of water. She doesn't win. So she finishes. She's going home. She's in her car. On her way home, calls her supervisor and says, "My head is hurting so much. I have a major headache." Bad, bad sign. This headache, and you'll see why. And then she was crying. That was the last thing anyone heard. And then in 2009, the family got $16.5 million in a lawsuit. So somebody died after a contest, basically. These are actually her real photos. This is her who died. And this is the timestamp. It is 9:01 a.m. That's Mrs. Strange. And this is 9:31. Do you think she was pregnant? That's the water. That's the bladder. You see? She was keeping the urine, right? The poor lady. That's one of her last photos in life. So what do you think happened, guys? What do you think happened? We don't have any physical example. I just saw it in the news. What happened to Mrs. Strange? That's the question. Is it pseudo hyponatremia? Cerebral edema, you think? That's why she had headache? I think I agree with you actually. Yeah. So she had acute hyponatremia due to water. They say water is the safest thing ever. Do you believe it now? No, it depends. If we do excessive stuff, it even water can hurt us. Similar to primary polydipsia, when you get a lot more water than osmoles in a very short period of time, you don't give the time to your body to adjust for it. You remember that bed when they gave 100 millimole of potassium to kill someone? We said 100 millimole is you and I what we eat. So why did it kill that person? Short period of time, no time for the body to for homeostasis, right? This is exactly what it is. And you were right. She had cerebral edema. Worst thing is when I am on the ward. I know somebody has hyponatremia. I go inside the room and she tells me I have a headache. Next stop is ICU. Headache, hyponatremia, you have just a few minutes to hours left in your life. Otherwise, you herniate, right? It's not the same headache as hypertension. If you have high blood pressure, you tell me, oh, I have a headache. I say, take 2 Tylenols. I have hyponatremia, I have headache, you go to ICU. Does that make sense? Yeah. Okay. So now let's come up with some imaginary questions. And I want you to concentrate very well. These questions are from me. They are not a standard. They're supposed to be very hard, actually. But I want to make you focus a little bit. If that victim had been taken to the ER once she developed headache, what could the lab findings have been? Only one answer is correct. Her serum sodium 136, her serum osmolality 281, her urine osmolality 55, her urine sodium 88. Which one do you think would be more fitting her status? You go with three. What would you go for? You don't have to be right. 280, you think? Okay. Who else goes for something else? Four, you go? The urine sodium of 88. Very good. We have had two, three, four. One. Anybody one? No. Actually, you know what? Think about it. She has completely normal kidneys. We assume she was 28 years old. Okay. She's drinking a lot of water. Do you think her urine should be dilute or concentrated? If the kidneys, everything is working very well in her, super dilute. The AVP should stop working. No AVP, no drop of water is coming back into the body. All the water should go out. So the urine osmolality should go up or should go down. Remember, we go from 50 to 1200 urine osmolality that we have. Do you think her urine osmolality should be as close to the lowest as possible? That doesn't that make sense to you? If she was completely normal, you check the urine should be super dilute, almost water, almost, right? Yeah. Why isn't other thing? Serum sodium of 130 is actually normal. 281 is a normal serum osmolality. So they are unlikely. Again, I don't have labs, but they're unlikely. Urine sodium of 88, again, if you have such a dilute urine, it is less likely to have such a high urine sodium. Urine sodium is around 20, 30, right? In normal situation. If you have dilute, it's probably less than 10 actually. Right. Okay. So we are good. Remember, I just go through the whole thing. Right one is easy. I told you, I repeat so much that you're going to be sick of it. On the right side, it's so easy. 5% of the cases, the serum osmolality is good. We don't have to worry. But if the serum osmolality is low, the majority of the cases, then you look at urine osmolality. If it is high, it is uh, what is it called? Concentrated urine. So you check urine sodium. Urine sodium is low, it is hypovolemia, and urine sodium is high, around 20, 30, whatever you go. It would be SIADH. Okay. They don't give you in the labs numbers that are close to 25, nobody gives you. 80, 90, or less than 10. Right? They make it very clear. Okay. If the urine osmolality is very low, which is the case for Mrs. Strange, probably. It is either, Lucy, all kinds of names I put. Beer potomania, I just told you, alcoholics, or we shouldn't call them alcoholics. We should call them what? People with alcohol problem, right? Diabetics, people with diabetes, hypertensives, people with hypertension. That's the new. I need to practice myself. So people with alcohol problem, they have what? They take all their calories through the alcohol, which is like free water. They don't have any osmoles. Another group of people that get hyponatremia, the um, mom and pops that are old. They are on fixed income. They don't have a lot of resources. So they call it tea and toast diet. Have you heard of it? They all have toast and tea, no solutes, no protein that produces BUN, right? So they tend to be hyponatremic. They have less osmoles and they drink a lot of water. Tea and toast diet. beer potomania, acute water um, intoxication, and primary polydipsia. That's a mechanism of defense in anxiety. Some people with anxiety, the only thing that makes them feel good is to drink water. And I'm not telling you about one water bottle here. We had in France, we had a patient, he came with this. We had to ask the plumbers to go inside his room and just close the tap water. He was going under tap water, drinking up to 25 liters a day. You see, that's a psychiatric disorder. It's not for you and me, right? It's somebody who really has psychiatric disorder, and this is how they compensate for that. Go ahead, please. The infections that go to the brain, yes, because the AVP goes up. Anything, encephalitis gives you AVP that is high, hyponatremia. Yes. Okay, so we went through all of this. Should we stay on that, Mrs. Strange, still? Just another hypo. Just think about it. If that victim had been treated with ED and all those, what would have been the best treatment for that lady? Isotonic saline, normal saline, hydrochlorothiazide, a thiazide diuretic that stops the sodium chloride transporter, and hypertonic saline or fluid restriction of 800 milliliters per day. Which one would you go for? Three. Hyponatremia is going to be treated at the same rate that it developed. If you just fluid restriction, the lady is in altered mental status. What fluid? Very good. Hypertonic saline. Perfect, perfect, perfect. Do I leave you alone? I don't. This is very difficult, this question, actually. This is coming from me. Assuming that a typical Western diet, and this is the real thing, if we are not a meat lover or something, we are around 800 milliosmoles per day. And if we are vegetarian, we go towards lower, right? BUN protein osmoles, right? So the more towards meat, the more osmoles we have. Let's say you and I, we have around 800 milliosmoles per day of solutes, okay? Ingested electrolytes and proteins exceeding what limit of electrolyte free water will result in hyponatremia in a person with intact maximal urine diluting Layman syndrome in a normal person where the AVP is working. Your maximal diluting capacity means that you can go all the way to 50. It's not like me that I am old, I'll go to 100 or 80, whatever, right? Let's say somebody can go dilute the urine all the way to 50. So what is the maximum fluid that somebody can get without getting hyponatremia? So basically, I'm asking you, you have 800 milliosmoles that goes in. Do you remember the concept yesterday? What goes in comes out. Same concept everywhere. For the osmoles is the same. So I have had 8 milliosmoles now. I have to get rid of 800 milliosmoles that day. Okay. If I can dilute my urine all the way to 50, how many liters of urine can I make without starting to make hyponatremia? 800 divided by 50. So this is, we need to excrete 800 milliosmoles in a day. Remember, urine maximal diluting capacity is 50. So remember, this is the slide that I put. So one can ingest up to 800 milliosmoles divided by 50 or 16 liters of free water without diluting serum and development of hyponatremia. It's a little bit difficult to understand. If you don't understand it, don't worry about it. At night, think about it. If you have problem, come to me tomorrow. Okay? If you don't get it, don't be worried. That's all I ask you. So 16 was the right now. Should we go for another case, guys? Okay. This is New England Journal of Medicine, July 2021. 45-year-old lady comes to the ED for evaluation of weakness, fatigue, and inability to concentrate. She has no significant past medical history. So she wanted to start a weight loss diet and started a week ago. Pineapple post increased hydration with diet soda and water. She has been drinking. Basically, she started a new diet that has pineapple and toast and all this. So she has been drinking approximately 4 liters of water or 1 gallon of water or diet soda per day since she started the diet. Blood pressure and everything is good. Okay, these are her labs, right? What are you looking in these labs? You look at the sodium is 123. Is it the problem? Yes. So what are the three things you and I we are going to look at? Serum osmolality, urine osmolality, urine sodium. Let's take a look. Did it give it to us? Yes. Serum osmolality is in the middle of the table here. Serum osmolality 254. Is it low or high? So do we go to the right side of the algorithm or left? It's the left one. It's unlucky, right? Okay. Then urine osmolality, what is it? 68. It is low or it is high? 100. So we don't have to go to the other side. We stay there. It's where we have a lot of water more than the osmoles, right? We're staying on that side. Do you agree with me? And you're going to see it here. So what is the most likely cause of this patient's hyponatremia? Cerebral salt wasting. It's where you have a lot of sodium going out. There's so that's mostly when they give you when you don't have another distractor. Low solute diet, diabetes insipidus, that's where you have ADH that is not actually produced, SIADH, and reset osmostat. When your serum osmolality that should be 280, in some people they have genetic thing for 250. But then they shouldn't get hyponatremia if you think about it, right? If it is the osmolality has been changed. Anyways, I put her numbers here. So we go through our algorithm. Serum osmolality. Is it high or normal? Right? No? We are not on this side. Forget about it. Let's go to our side. Low. Urine osmolality. Is it low? Okay. Primary polydipsia. This is a lady who has gone more water, more fluid, electrolyte free fluid than osmoles. And it tells you 1 week later, they started to get pineapple toast water. Right? Excellent, excellent. Low solute diet, high fluid intake, beer potomania, Tiantos diet. You can call it any name that you want. But the point is, you take a lot of water, not a lot of osmoles. Low solute diet. So if she's having, let's go through this. This is my question, not any JF. If she's having a low solute diet, instead of 600, 800 milliosmoles per day, let's go, she's going to 260 milliosmoles per day, right? Not a lot of meat, not a lot of things. 260 only instead of 600 or 800. What is the amount of fluid that she can get without getting hyponatremia? If everything works, she can dilute her urine as much as she wants from 50 to 1200. So again, 260 or 280 divided by 68, right? She has 280 milliosmoles to excrete, and she can go to 68 milliosmoles per liter is the maximal diluting capacity. I gave her instead of 50, I gave her 68 because she's a little bit older, right? We said 50 is the lowest you can go. Some people cannot go as low depending on the age. 4 liters. So basically, what I want you to learn from this session is that the less solute you have, the less capacity you have to adjust for free water. If you are vegetarian, you cannot drink 8 liters of water. That's normal life, regardless of USMLE. Does that make sense? But if you are meat lover or you have normal diet, then you can go as much as you want. In normal situation, you will never get hurt by getting fluid. So that would be. So what is the best way to treat this patient hyponatremia? So she came to you 1 week of whatever diet, so she was in a bad shape. The main osmoles we said is sodium, urea, glucose. Do you remember that? We talked about it. Okay. Serum osmolality is calculated this way: 2 times sodium, glucose divided by 18, urea divided by 2.8, right? And we said normal is around 280. What is the best way to treat this patient? Sodium glucosuria. You take him to a burger place, her to the burger place. Which one would it be better for her? More protein or less protein? More BUN or less BUN? On the right side, I agree with you. You see, that's the beauty of nephrology. How many specialties tell you to get burgers? Think about it. And do you think she should get not a lot of pickles or a lot of pickles? We want to increase her osmolality, remember? Yeah, that will really help her diet. So, should she get water or soda? Think about it. What's sugar? That's why it was telling you diet soda in the case it was telling you. No sugar, no osmoles. How do you want to handle your free water? Right? So here we are. Case number 5. I don't know if we have time for it or I should let it go. Okay, I think we are good with this. Yeah, it's exactly 50 minutes. Perfect. Thank you so very much for your attention.